I am greatly honored to be asked to speak to you today about something that IPA has been intimately involved in over the last 1 year, and this pertains to how we responded. It is a larger body of work than what I am able to share today, but I will try and focus on some of the bigger issues. So amazing as we speak today, that officially we are up to almost 157 million cases of COVID worldwide and close to around 3.25 million deaths. And they've affected every country in the world over the last 1 year and a bit. And it is possible that this is a gross underestimate. A report just released 2 days ago by the Institute for Health Metrics and Evaluation has systematically looked at reporting systems and indicated that we may be close to 7 million deaths worldwide if you recognize how many COVID patients have died without a diagnosis or without a molecular test, or died at home without a confirmation. So it is a sobering pandemic with a mortality impact which is fast approaching what we had potentially 100 years ago with the Great Flu pandemic. Now, at a very early stage of this pandemic, I and my colleagues, we set up a COVID working group, and I would like to acknowledge them at the very outset. This is a group of young scholars and some scientists who have worked collaboratively across continents. They include people from Pakistan, other parts of South Asia, Australia, and Canada, who have worked together on various aspects. And I think we all owe them a tremendous debt of gratitude for the work that they've done. And notably, I'd like to point out Dr. Kun Tang from Tsinghua University in China, who was a visiting scholar with me, and Omar Irfan, who has led a lot of the systematic reviews. So what I would like to cover today is the spectrum and diversity of pediatric disease worldwide. What do we know over the last 1 year? Something about multi-inflammatory syndrome that has so been a focus of attention across the world. I talk about indirect effects of COVID-19 that unfortunately haven't received as much attention by at least the pediatric societies as one would have thought. I'm going to specifically talk about schools and transmission risks, an area in which Professor Russell Weiner and his team have worked and led from the front. And I'll try and summarize some of that information based on a recent analysis that we've done as well. And finally, I would like to finish with some thoughts on what we might want to do together as a global body of pediatricians. So let's start with the mother, something that we typically would do for newborn health, and look at COVID-19 and pregnancy. And from an early stage of the pandemic, it was evident that this illness, this viral infection, had every propensity of affecting pregnancies. Although at that stage, much of what was coming to the fore was towards the latter end of pregnancy, so late pregnancy. And as time has gone on, we have evolved in our understanding from what was initially thought to be a very mild infection with no real consequences in pregnancy, to now a recognition that it can have quite significant impacts through both systemic inflammation, decompensation, which can lead to vascular complications in pregnancy, and adverse fetal development. So a recent systematic review by our group has looked at close to 62 pooled studies in a pooled analysis, with both studies from single countries or multiple centers and multi-country analyses. And this has included data from virtually all regions of the world. You will notice a relative paucity of information from Africa, and there's been a pretty uniform finding across many of these systematic reviews that we don't have the same universality of reporting from various regions. But this particular systematic review looks at around 30,000 consecutive cases, with around 3,000 where severity of illness has been documented. And as you can see in this graphic, if you have severe COVID-19 in pregnancy, you have quite significant consequences ranging from neonatal infections to ICU admissions, prematurity rates, and excess stillbirth rates. This has also been systematically looked recently in the inter-COVID study that we just published a couple of weeks ago in JAMA, And if you look at the intra-COVID study, which looked at around 20 centers worldwide, including many in low and middle income settings, there are significant differences in outcomes related to severity of illness, as well as whether or not you had a positive diagnosis based on PCR testing. And if you look at the blue line, which is a symptomatic PCR diagnosed COVID infection in pregnancy, you will find that this curve is significantly different with reduced gestational age, higher rates of prematurity in this particular population. And remember, at an early stage of COVID-19, it was thought that perhaps at population level, prematurity rates had actually gone down. Now, in this particular analysis, a complex series of outcomes were summarized as severe neonatal morbidity and severe perinatal and maternal morbidity. You see that highlighted here in these two columns using controls where there was no COVID as a reference. And just very simply, if you were a positively diagnosed mother with a test positive neonate, your propensity for adverse outcomes were about 4 and 3.5 folds higher. And these include a range of outcomes, including hypoxic ischemic encephalopathy, sepsis, PDA, intraventricular hemorrhage. So it looks like there is a higher risk of adverse perinatal outcomes with severe COVID-19 infection. Now, sadly, we don't know very much about early infections in pregnancy because, unlike Zika, there is not a lot of information available yet, but it is increasing, and it's possible that we may see much greater information over the next 6 months emerging. But I want you to see one more finding from this recent publication, which was also amongst asymptomatic mothers with positive COVID-19 diagnosis. And you will notice that the rates of neonatal morbidity were, although not significantly higher, but the direction of effect was higher. And you also saw higher impact on maternal morbidity and preeclampsia in that subpopulation. So, ladies and gentlemen, this is not a mild infection in pregnancy. And all the more reason for us to work hand in glove with our obstetric colleagues in ensuring that women are provided COVID-19 vaccinations soon, and proper studies are undertaken in that population to reduce risk of adverse outcomes. What IPA has done is actually worked with UNICEF, to which I'm very grateful for the collaboration and the partnership that they provided, and WHO, in producing several policy briefs. This is a brief that's just about to come out, which is on what should we do with mothers and newborns in terms of ensuring that we do no harm. And we're very grateful to support from USAID in making this happen. And essentially what it says is that we must make sure that we try and maximize essential services, that we do our level best to ensure that even though there are fewer contact times and with lockdowns and what have you, fewer opportunities for these stipulated 8 antenatal care visits as required by WHO, that we maximize the quality of those visits whenever they take place, and we offer universal screening for COVID-19 to all pregnant women, particularly those in hyperendemic areas. We also underscore the extremely important message of not separating the mother and baby and ensuring that all babies are breastfed as they receive their mother's milk, because all the earlier thoughts about vertical transmission and the risks of infection passing from the mother to the newborn have been proven to be not true, except for a few rare instances where there might be such reports, but by and large, everybody believes that it is the best option is to keep the mother and baby together. So that's the first example of a product with UNICEF collaboration. What about children and COVID and direct effects? And from an early stage, this has been a focus of attention. We produced a policy brief with UNICEF earlier on last year. It seems already quite a long time ago, and an update of this is coming. I'll talk a little bit about the review that was published in the Lancet Infectious Diseases and a recent systematic review undertaken in partnership with IPA that was published in Archives of Disease in Childhood. As you will see, just like the maternal studies, these represent studies from virtually all over the world, with a notable deficit in Africa. There's only one systematic review that's come out of Africa that we have included, but these 129 case series represent what is known, with now a lot more from low and middle income countries than was available when we did our first review. So what do we know? So firstly, the majority of infections in children, as you can see here in this forest plot, are mild, and they have symptoms which are pretty protean with the kind of things that you will have with viral infections in children. You will notice that a significant proportion of children who do get hospitalized have comorbidities, and fever by and large is the commonest feature that you see in about 2/3 or 3/4 of children. In terms of treatments, there is now pretty standard consensus that the best treatment for non-severe COVID in children is observation and symptomatic treatment only. And I will speak a little later about what pediatricians can do to overcome the infodemic of all kinds of inappropriate treatment protocols that are being circulated everywhere for COVID-19 in children, which are unnecessary for mild infections and for those cases that do not require hospitalization. But you will notice that overall in the literature now, a whole range of things have been tried, ranging from antivirals to antimalarials, and now the favorite medication that everybody's using, ivermectin, which we don't believe is necessary for many of these children. But a few things I would like to point out that we know. So earlier on from the European experience, it was thought that there really is no difference in terms of a range of outcomes such as hospitalization, severe cases, crude case fatality, etc., by various age groups in children. There was no difference seen between young children, school-age children, and adolescents. And this is largely from the data that was compiled in Scandinavia. However, when you look at this across the world, just like we know for adult COVID, we find some stark differences. So out of these 67 case series of pediatric COVID that have been reviewed and published recently, you will notice that there's a gradient of mortality, and that the older you get towards adolescence, your case fatality rates are in excess of 1%, several folds higher than that for younger children. We also looked at differences in patterns between low and middle income country cases and high income country cases. And we had a reasonably robust sample size of around 3,000 cases reported for each. And just eyeballing this in terms of symptomatology is not a lot of difference in this forest plot between high income and low income cases in the way children present. Yet outcomes are very different. And on this particular slide, you will see on the one end, the admission to intensive care unit, about threefold difference in case series from LMICs compared to high income countries, also reflected in lower ventilation rates. But importantly, as I will point out to you, case fatality rates from low middle income countries are higher. And I believe, as do my colleagues, that this reflects to a large extent differences in health system performance. So the take-home message from here for pediatricians is that everywhere children should receive standard of care that is possible to reduce case fatality to levels that have been seen in many high-income settings, and generally should not exceed 3% of those hospitalized. Multi-inflammatory syndrome, we produced one of the earliest reviews on this at that time, in August last year, when we were looking at around about 30 systematic reviews and reports related to this disorder. That figure is now up to 86. And these again are distributed across many parts of Asia, Europe, and North America, with much greater reports coming from high-income countries. If you look at the patterns or symptoms of these 3,000 or so children from 86 studies with multi-inflammatory syndrome, a large proportion do present with features consistent with what Mike Levine has described as Kawasaki-like disease, and with features that are quite reminiscent of a systemic vasculitis. But you will notice that about 1/3 also have neurological symptoms, and a significant proportion 35 to 40% present with shock. So it does require a fairly close watch, and most of these children with multi-inflammatory syndrome should be hospitalized and receive treatment. In terms of lab and radiological markers, this particular slide also shows you what we know from the literature that children present with. And increasingly, as people begin to use greater tools and technology in terms of looking at D-dimers and troponins, you will find that they are the dominant finding in about 2/3 to 3/4 of such children. Again, coming to outcomes and treatment, they have received a wide variety of treatments ranging from intravenous immune globulins, antibiotics, steroids, and anticoagulation support. And there's not a lot of difference between how children have been treated in high-income settings versus low-income settings, except that a greater proportion of high-income settings institutions have been able to offer things like ECMO and additional therapies. But I want you to look at outcomes, and I'll point those out here on this slide summary, that again, just like we saw with general COVID, that there is a significant difference, a 4-fold higher case fatality rate, not surprisingly, in low and middle income settings. And that potentially is related to the fact that only half of these children received ICU care. So a big lesson here for pediatricians in terms of ensuring that children who do get hospitalized with multi-inflammatory syndrome receive the kind of special care that will lead to better outcomes, in the absence of which you will encounter the kind of case fatality rates that you see here overall. So to summarize our direct impact of COVID in children, maternal symptomatic and severe COVID infection is associated with significantly higher risk of adverse perinatal neonatal outcomes. Generally, children less than 19 years of age comprise a small proportion of total reported COVID cases, but this may be changing with increasing burden and spread, as well as generalized population immunization rates. And I'll come back to this later in my presentation. Generally, pediatric COVID is a milder disease than adults, with a predominance of infections in school-age children, a slight male predisposition, and a higher propensity of infections with severity in children with comorbidities. And I've already spoken about MISC, which is something that every pediatrician should be aware of. Now, in general, people ask the question, and Nigel Curtis and his colleagues have looked at this as to why COVID-19 is less severe in children. And there are multiple theories as to why this should be the case in comparison with adults, of which the notable few things that people talk about are that perhaps there are indirect effects of live vaccines, because children generally have greater exposure to vaccines than adults. Perhaps there is reduced intensity of viral exposure, dose effect, and that there might be some differences in innate immunity at a younger age, where they have stronger immune responses because their immune system is potentially catching up in terms of adaptation. But we don't quite know 100%. And as I said, you will encounter severe disease in children, so one should not let one's guard down and imagine that every COVID-19 infection in children, particularly older children, adolescents, is going to be mild. Let me turn to the indirect effects of COVID-19, on which we are very grateful again for collaboration with UNICEF. This is the study that I'm going to share with you is a study that was done in depth in South Asia and has recently been reported and published and is being updated. So if you look at indirect effects, you are looking at populations where COVID-19 has been a big problem and has led to mitigation strategies that could have unintended consequences. So in South Asia, as you know, although the rates and numbers were initially not as high as you saw in Europe and in North America, the region has of late seen a phenomenal increase in COVID-19 cases. And our heart goes out to our colleagues who are fighting a heroic battle against COVID-19 in India, and our greatest support for them in this endeavor. But you will see that all of this has put an enormous strain on the system. But I'm not talking about the current scenario, I'm talking about what happened last year. And as you will notice, at various stages, there was a first wave. In India, the first wave really continued. In other places, you had a second wave, and this was all associated with mitigation strategies that included school closures, workplace closures, travel bans, curfews, and they ranged from very strict imposition of these restrictions to relatively modest restrictions. And in South Asia, in the countries that I'm mentioning here, almost all virtually closed by the end of April, beginning of May, June. And then they have all relaxed at different paces. But in many instances, notably in Bangladesh, the stringency index still remains very high. Now, what has been the consequence of this? Let's just pick up a few. And I'm going to talk about school closures. Schools were one of the first victims of COVID-19 fear, and they closed pretty earlier on. And although they changed in terms of many countries opening them partially, closing them again, by and large, as we speak now, schools are still closed in many geographies. And actually, children have lost almost a year and a half of their academic time. Now, why does it matter? Now, of course, disruption of health services that all of us know, such as reduced access to immunizations or to vaccination centers or to health support services, can lead to direct effects on outcomes. But disruption of education has huge consequences developmentally and also on subpopulations such as adolescent girls who will drop out of school after a particular period of time and be married off. And that, as a consequence, is not something that's been appreciated significantly. And there are obviously indirect effects in children on reduced economic activity, on food insecurity, all of which leads to indirect impact on children, families, adolescents. Let's look at some of those estimates. Now, I'm only going to give you one estimate of disruption of health services from my own country, Pakistan. These are actual data from health management information systems. These are district level data. And in the blue bars are what were projected to be potential disruptions. And the orange bars are actuals as to what has actually happened. And you will see that for many things, the disruptions have continued right into Q4. Vaccinations have recovered somewhat, but nothing has recovered to pre-pandemic levels. And now I fear that even in India, that did a good job in terms of recovery from Q3, Q4, that there would be a disruption after this recent upsurge. What is the consequence of this? Our estimates and our extrapolation from the reduced coverage rates using a LifeSafe tool model shows clearly that there's potentially a 10 to 11% increase in maternal and child mortality over this period. We estimate for South Asia alone, there are 180,000 additional deaths, and close to around 1.7 million unintended pregnancies and their consequences in terms of unsafe abortions. For education, over 400 million school-age children in South Asia have been out of school since March. And a third of those, at least, I believe actually up to half, have not been reached by remote learning methods or virtual learning. There is no way rural populations can have access to the same in terms of tutoring. And this loss of educational achievement, learning time, and potential developmental deficits are particularly severe in younger children. And they're not things that children will catch up on readily because they are at such sensitive time periods. Just out of adolescence, we think 4.5 million girls have potentially dropped out of school, of which many would have been married off. And the impact, therefore, of these excess adolescent pregnancies, which already in a region where a quarter of all births are in an adolescent period, can be enormous over time. Why am I raising this? Because I wish there was more that pediatric societies had done in terms of being the voice of reason and advocating for children to receive their due share. And many of the schools were closed not only because of risks that parents felt for children, but because of the fear that if you open schooling, you may impact overall burdens enormously. In March last year, UNICEF put out a report, which in my opinion was a prescient report on COVID-19 in children. And what they said at that time, that children may not be the face of the pandemic, but they risk being amongst its biggest victims, as their lives may be changed in profound ways. And this is exactly what has happened, ladies and gentlemen, with this pandemic. I'm trying to put a positive spin on this in terms of what we have been able to do and can do, but the fact remains that children have been great victims of the pandemic in multiple ways, with mental health issues, with learning opportunities restricted, and also impact on their lifestyle and health and nutrition. And this impact has also been shown to have huge socioeconomic gradients. Here in Toronto, we recently just had a look at immunization deficits, and they're significantly greater for people who belong to either immigrants or ethnically marginalized populations. This is a universal crisis, and the impact on some of these children may be lifelong. And in order to mitigate for this, we really need to be targeting children at greatest risk. So let me come to my final section, which is about schools. And I acknowledge the phenomenal work that Russell Weiner has done in this regards. We've looked at this through a systematic review of whatever is available in recent, and this paper is coming out in Journal of Global Health anytime now. And these are close to around 90 studies that have looked at both national, regional prevalence, as well as schools with contact tracing. And in the interest of time, I'm only going to summarize three things. So first is, what are the odds of being infected by age amongst children going to schools? And simply placed, young children have lower odds of infection compared to adolescents. So about 40% lower odds than adults. So it's clear that in consonance with what I've just told you about general epidemiology, children's risk of acquiring COVID-19 in schools is not massive compared to adults who are going out about their own business. What about contracting infections in different types of schools by grades? And here we looked at daycare centers, primary schools, and high schools. And what you can see very clearly here is that the risk of contracting COVID-19 is the lowest in daycare and preschool settings, the exact age group that we've been fighting in terms of keeping them open. Here in Canada, fortunately, daycare centers and preschool children could go to school. In other places, we fought a losing battle in terms of keeping primary schools open. And I think that was a big mistake. But in moving forward, if we have to make closures, we should keep younger children in schools because they cannot learn remotely, and they are also at a very significant risk of developmental deficits if that window of opportunity is lost. What about the odds of being an infected contact in children versus adults, whether their schools are open or closed? That's a very big question. I mean, do you have greater rates of infections if schools are open or if schools are closed? Large number of studies that have looked at this. But to summarize, actually, it makes no difference. And if anything, the risk or the odds of being infected when schools are open or partially open are lower than when schools are closed. And this is an important point to take home, that you don't really increase the risk of community-based infections if schools are open. There may be the risk to teachers, but they can be vaccinated. So as we move forward in terms of indirect effects of COVID, we must recognize that they may be much worse than the direct effects. And younger children have a lower susceptibility, but a comparable risk of infection is seen in adolescents, and that has huge implications for adolescent immunization. And in moving forward, by now, I would have thought that there would have been a lot of trials on various strategies to keep schools open. But sadly, I don't think there have been very many, particularly in low and middle income countries, with open air schools or other modalities to reduce risk of infection. But immunizations are the way forward. And I'm very glad that we have this recent results come out, and I think we will have the Pfizer vaccine license for use in adolescents in the United States very soon. It's already been approved for immunizations in adolescents here in Canada, and this particular trial in adolescents showed 100% efficacy and robust antibody responses. So let me close, ladies and gentlemen, with some final thoughts for the IPA. You've done very well, as have many regional and national societies, in keeping the body of pediatricians closely knit together, globally informed and connected. And I think what we have learned, like we're doing today with this landmark virtual meeting, is that we can stay connected without flying people across the world and without expensive arrangements in five-star hotels. So you get full marks for this. And I'd like to pay a tribute to Naveen Tucker for leading from the front in making this happen. We have had a great focus on immunization strategies. Why? Because these are close to pediatricians' hearts, and they were one of the first things to suffer during COVID-19. But there are many other aspects, as I pointed out to you. And I think we could have done better in relation to mental health, to adolescent health, and information about severe COVID. And we can do this moving forward. So here it's a call for doing better. You've heard about the IPA COVID-19 working group. I would really call upon the leadership of the IPA, as I personally step off the executive committee, to keep that working group going, because it is our bridge to not only a lot of evidence-based policies and guidelines that many agencies develop, but our own engagement in building that knowledge pool and in doing many of these syntheses, like I've shared with you, also keeps us at the forefront of academic pediatrics. And this is extremely important given the infodemic that I talked about, the deluge of incorrect, inaccurate, and frankly, sometimes harmful information that is easily available on the web, sometimes spewed by pediatricians themselves. And be prepared, be humble, recognize that this is an illness in which the global knowledge pool is only a year and a bit old. And we don't know enough about this disorder yet to be very prescriptive or absolute in our beliefs. We are learning every day now, and be prepared for a changing landscape as we begin to see different epidemiology. And I'd like to finish by just showing you that in the US, thanks to the good work by the American Academy of Pediatrics, we've kept track on this now, and we recognize that pediatric cases in the United States now account for about a fifth of all cases. And that's partly because of the reduction in infection amongst adults and immunizations therein. But when you have about a fifth of all COVID cases being in children, that also means that children's welfare, well-being, and also their potential prevention strategies come to the fore. And I believe by next year, we should have COVID-19 vaccinations as routine vaccinations in children. Thank you very much for your attention.